Bismillahirrahmanirrahim. I think my task has already been made simpler by the very comprehensive and exhaustive talk on the procedure and its complications. So I'll just go through quickly my slides, just summarizing very briefly the complications that we come across during this TAVI procedure. Just talking about the mitral clip, it reminded me the procedure, which was the first procedure which was done by Professor Farkat Alamgir when he came to AFIC as the first procedure of mitral clip in Pakistan, and I was also part of the of that team holding the TOE Pro with Colonel Sajjad. And it went very well, and the patient had significant symptomatic improvement and for a year or so, and then he had a stroke incidentally afterwards. So with the advent of the Partner 3 trial, which basically has compared low-risk patients with surgical arm, and it has definitely paved the way further for further use of this percutaneous approach for aortic valve. More and more patients with the disease are going to be candidates in future, and only the difference was in the use of pacemakers. But all other parameters, particularly the primary outcome, that is the death and the stroke and the rehospitalization, was better than the surgical arm. Now, just summarizing the complications, we can divide it into cardiovascular complications or non-cardiovascular. And the cardiovascular, the major complications that some of which has already been dealt with very comprehensively. These include the coronary occlusion, the aortic regurgitation or paravalvular leaks, arrhythmias, conduction abnormalities, rupture of the aortic root, and mitral valve interference in general. Paravalvular leak is one of the important parameters which has bearing on the long-term outcome of the patients with this procedure. Although with the meticulous measurement of the annulus and with the help of the multi-slice CT, this and with improvement in further device with the use of skirt in by different vendors, this complication has come down, and and this paravalvular leak is also decreases with the passage of time. So the percentage with which the patient can have this paravalvular leak varies between 4 to 35%, but definitely it has been brought down with the modification in the device. The pathophysiology or basic reasons for or causes of a paravalvular leak are basically the very heavily calcific valve, or malpositioning of the valve, again in those cases where the valves are heavily calcified. Similarly, the undersizing of the valve or even the underexpanded valve can lead to paravalvular leak. And again, with the use of multi-slice CT and with the meticulous measurement of the annulus sizing, most of the paravalvular leak has been mitigated quite a lot in recent procedures. So this is the slide just depicting the mechanisms of the paravalvular leak, that is the heavily calcified valve, the slightly higher placement of the valve, the deployment of the valve quite lower down, and the undersizing of the as compared to the annulus. Well, this was more seen with the first generation valve. As I mentioned, with the second generation valve, the paravalvular leak has definitely reduced. But important thing is that the paravalvular leak is associated with long-term morbidity and mortality in these cases. So there is a particular emphasis on reducing the paravalvular leak during this procedure. The other complication is stroke. Even in the lately published trial, that is the Partner 3 trial, the incidence of stroke was around 23%. The pathophysiology of stroke is basically related to the migration of the debris and atherosclerotic plaque from the site of the aortic valve or from the ascending aorta. And it usually has a bimodal presentation. Either the patient, they develop stroke at the time of procedure, or the second peak is around 10 days, but some patient may develop stroke even after 2 months. One of the factors in the development of stroke late is the incomplete endothelialization of the valve. So, in order to reduce or mitigate this complication, there has been a lot of interest in using the cerebral embolic protection devices. And there are a number of devices which are being used, which give protection of the head vessels, that is the brachiocephalic, the carotid, and some do the complete protection, including the left subclavian as well. But incidentally, it has added to the cost of the procedure, and the use of these protection devices has been very less. Even in the Partner 3 trial, it was only 2%, only in 2% of the cases this device was used. So there is not a universal recommendation to use embolic protection devices in order to reduce the incidence of stroke. But it does help in the, it has been shown in some trial that it does help in reduction of the deterioration or impairment of the cognitive function of the individuals. Coronary occlusion at the time of procedure is quite uncommon, but it's a very catastrophic complication. And one of the mechanism is the impingement of the valve leaflets or the native valve leaflets in front of the coronary ostia. And this is more common in patients in valve-in-valve procedure, where previously bulky bioprosthetic valve, they impinge upon the coronary ostia. Well, so in this patient, there is sudden exclusion of the left main stem, and which was, I think, they tackled with the use of immediate use of left side cannulation and placement of the stent. Then aortic or annular rupture is another very catastrophic complication, which has a mortality of around 50 to 80%. It is mostly associated with the balloon expandable valve. It is seen very less commonly with the cell expanding valve. The only way out from, as I said, the mortality is very high, and the only way to save the patient is to convert to the surgical procedure. In some cases, there are case reports of saving the patient with the help of another valve in those cases where there was contained rupture. So the common site of rupture is aortic annulus in 2/3 of the cases. Then the sinusal valsalva may be the site of rupture, LVOT, and sinotubular junction. The risk factors for the annular rupture are basically the oversized valve or very heavily calcified, particularly if the calcification extends into the LVOT region. I think Dr. Asad has already talked about the vascular injury very comprehensively. Basically, these are related to the pre-existing vascular disease in the femoral region. The frequency of these vascular complications, they range from, in different trials, in different registries, varies from 5 to 23%. But as Dr. Asad mentioned, that keeping a backup wire from the contralateral side help in reducing the in the case of there is some leak or the rupture, we can use that wire as a backup to track the balloon to do the balloon tamponade immediately, and then we can do the further if there is a and then when we can use the covered stent for if there is no stoppage of bleeding with the balloon tamponade. Well, regarding the conduction abnormalities, that is basically said to be the Achilles heel of this percutaneous procedure. And in different series, in general, with the help of self-expanding valve, the conduction abnormalities, they range from 18 to 65%, and slightly lesser with the balloon expandable valve, that is the sapien valve, which ranges from 4 to 30%. Left bundle branch block is commonly seen because of the impingement of the valve onto the LVOT region, which is the site of the left bundle branch block area. In some cases, it may disappear after some time, but if it persists for more than 7 days, almost 50% cases of they end up with the placement of the pacemaker. Some of the predictors for development of pacemaker are if there is already conduction abnormalities like first degree heart block or bifascicular block. These patients are more prone to have they are more prone to end up in the pacemaker implantation. Presence of RBB is a more sinister predictor if it is present before the procedure, and then these patients would rather are more likely to have end up in a pacemaker implantation as compared to the left bundle branch block. Other less frequent complication is the stent embolization, as Dr. has already shown. It is a nightmare for the operator at the time. Then how to tackle with that? Obviously, if it pops up, then you have to use another valve in some patient, and if it pops up just above the annulus, then you have to drag the valve from that area in order to implant the second valve to make room for in these cases. There are very rare reports of delayed embolization. Well, there might be some other valve. I'll not go into the details of structural valve degeneration. Valve thrombosis and endocarditis may be one of the complications may be seen in some cases. Similarly, the pericardial effusion and tamponade is associated with the guide wire that Dr. Asad has already talked about, and these are to be dealt with as they come up, depending on the hemodynamic status of the patient. Well, some very uncommonly non-cardiovascular complications could be acute kidney injury, hemolysis, and acquired von Willebrand disease, sepsis, and sometimes radiation injury. So just to conclude, it is essential for the heart team to discuss bailout options, including conversion to open heart surgery. Procedural planning is key to prevent potentially catastrophic complications. Pre-procedural imaging is essential to plan vascular access. Ultimately, all members of the heart team need to understand strategies for the prevention and management of procedural complications during TAVI procedure. Thank you very much for listening.